I'd like to welcome our audience to our continuing series of Carestream Talks. Today's topic is going to be on bedside imaging. I'm Charlie Hicks, the General Manager of our Digital Medical Systems here at Carestream, and in this edition, we're going to be talking a little bit about innovation in bedside imaging. Today, we have the pleasure of having Glenn Nicholson as my guest. Glenn's our Worldwide Product Line Manager for our mobile solutions. Welcome, Glenn. Perhaps you could tell the audience a little bit about your background.
Thanks, Charlie. So a little bit about my background is first and foremost, I am an X-ray technologist and have been for over 20 years now. Worked from anywhere from a large educational facility to a small private remote clinic. And just prior to my taking the job as a product line manager, my latest position within Carestream was as a product specialist and sales specialist out of Canada.
So Glenn, you've had a ton of years working in bedside imaging. For me, it seems like the amount and the volume of bedside imaging is increasing. Is that true? What's your feelings about the bedside imaging and the importance of it lately?
Yeah, so I would agree with you, Charlie, for a couple of reasons. One is the advent of technology. So with the advent of DR, image quality has gotten much better. And I think you're seeing requests for some bedside imaging that maybe would have come to the department beforehand. And again, it's just all about image quality. So it's just really about patient care. So if I can complete an examination at the bedside that gives me, good quality image and it makes it easier for the patient, then all the better for sure. Often within a facility, a portable examination could be ordered simply because it can get completed faster than having a patient transported down to the diagnostic imaging department. And then again, coming back to DR is that, or any digital image, is that images are available immediately to view by the clinicians, and they can view that either via PACS or often right on the mobile unit itself. So, and then the other thing is with transportation. So coming back to some patient care is that, if I don't have to transport a very ill patient down to the X-ray department, it can be time consuming, it can be a little bit of a logistic nightmare at times. I have to have a porter involved on the floor. I have to have a nurse or two involved to help with a transfer, and then I have to bring the patient down, and often they're waiting for a few minutes or more than a few minutes for their images to be taken, then it needs to be done all in reverse. So if I can avoid that, make it easier on the patient, but still provide a high quality diagnostic image, then all the better for everybody involved.
Yeah, I would think that moving a patient, in addition to just all the resources and the complications of moving that there's also an additional risk of moving those patients. I mean, they're our most critically ill patients a lot of times, and transporting them must have some additional risk to them. So I agree. I think coming bedside is just the better way to do it. Of course, coming bedside means you got to get that equipment to them. And you and I have been in a lot of hospitals, and it's interesting because you can hear this equipment coming down the halls. You hear the motors. They come into the ICUs. A lot of times the patients are asleep. A lot of clicking, clacking. A lot of as things get docked and undocked. So I know there's been a real strong initiative under the name of Hush, and this is to actually reduce the noise of the environment. Can you maybe expand a little bit more about Hush?
Yeah, for sure, Charlie. And you could always hear that, especially the oldest portable coming down the hallway, banging and clanging, as you said. But overall, studies have shown that the best way, or one of the best ways, to support the healing process of patients is to have a quiet environment. So the Hush initiative, and the acronym stands for Help Us Support Healing, came out of the nursing community, actually. And that was just to have a quiet place, a quiet environment for patient. Most recently with our DRX Revolution is that our drive motors were redesigned to reduce the overall noise when it was driving around. And one of the bigger changes is the reduction in brake noises that we had. So when you either engage or release a brake, the noise that was there previously has virtually gone away. And then on our other product, the DRX Revolution Nano, it is not battery driven, and that system itself is virtually silent. You really wouldn't know that it was coming, and same with the locks as well. That noise has been greatly reduced.
So now all I have to worry about is you sneaking up on me then, right?
Exactly. Just take it lightly, Charlie.
All right. Now, in addition to some of those hardware improvements we made around Hush, we also have quite a few software improvements that have been made over the years. You know, things that come to mind are smart grid, pick and line placement. There's a whole long list. Maybe you could expand a little bit more for the audience on some of the algorithms that we have built into the software to help them on the bedside patient imaging.
Yeah, for sure. So the first one I'll pick on is what we call tube and line software. So by virtue of its name, we'll show you where tube and lines are, but it can also be used for other purposes, i.e. Foreign bodies, for instance. What that software does when it's enabled is that you take your clinical image, and then the software makes a copy of that clinical image, and we call that a companion image. When it makes a copy of that, the algorithm gets applied to it, and then becomes really an undiagnostic image, but those lines and tubes kind of light up for you. So if you're a facility that has a standing order for a X-ray post NG tube insert, is that the technologist will go up and take that image, and for myself, I'd like to call it a chabdomen. It's not really a chest, it's not really an abdomen, it's a little bit of a combination of the two. And so for me as a technologist, I used to have to window and level that image so that it makes sure I could see the NG tube, and that kind of all goes away with the line and tube software. So that companion image is available obviously to the technologist to view, but also to the clinician, maybe the intensivist, and also to the radiologist. So this, from a workflow perspective, it cuts down on everybody kind of having to window and level everything. It just will demonstrate any kind of changes to the patient as well.
One of the things we also talked about was smart grid. So we all know that scatter radiation degrades an image significantly, reduces contrast, and a lot of the detail that's in the image. The traditional way of doing that was to use a physical grid, and that comes with a lot of complications. It's a heavier piece of device. You have to use additional dose. What's this concept of smart grid?
Yeah, so essentially, basically, Charlie, is that the concept is that the smart grid software replaces a physical grid. So traditionally, when I need to use a grid as a technologist, I would put my detector into the grid or my grid onto the detector, put that behind the patient, and take my image. So the way that smart grid software works is that it analyzes that image I've taken without a physical grid and picks up that kind of scatter radiation that's hit it, eliminates that scatter radiation from the image itself, and then provides me with an image that has obviously a reduction in scatter, and will provide me with an image that is as good or better than if I used a physical grid. So for me as a technologist, what does that mean to me is, I didn't have to lift the heavy grid along with the detector and put it behind the patient. I don't have to take it back off. And I've also lowered the dose to my patient, because I would not use the same exposure factors that I would use if I used a physical grid, but I'll get just as good or better of an image in the back.
So we've talked a lot. We talked about patient care, patient comfort. We talked a little bit about dose, faster diagnosis, improved workflow. One of the top hot topics that we haven't talked about is about infection control. What are some of your thoughts about infection control and what that means, especially when you're doing bedside imaging?
Yeah, for sure. So first and foremost, Charlie, is infection control has always been a priority within any healthcare facility. It's and of course it's only been emphasized with COVID-19 coming along. So a couple of things on our DRX Revolution cart itself I'll speak to is there's dedicated storage on the unit for most facilities use some type of a cleaner wipe in today's environment. So there's dedicated storage for the cleaner wipe right there. So there's really no reason to kind of hunt down for a cleaner. And then we've made a few changes recently with our monitors on the system, and that is they're just more resistant to any fluid ingress. You no longer have a monitor kind of acting up on you for a short period of time. But when you talk about bedside imaging and its uptick that we talked about earlier in infection control, so if I can limit a potentially infectious patient from moving around the facility and still get an image for them, a diagnostic image for them, then that just kind of cuts down the risk of exposures to others within the facility. And then take that a step further is if I can now offer bedside imaging, and we talked about patient transport earlier. So if I can eliminate that transport early, if I can eliminate the porter coming in contact with that patient, if I can eliminate a nurse or two or support staff from coming into contact with that patient to transport them, then again, I've just cut down the number of people that have direct contact with that potentially infectious patient. And then take that one step further, and that is if I can cut down the number of people, I'll cut down on the amount of PPE that I'll need to use within the facility. And we all know that since March of this year that we've had some struggles worldwide with the amount of PPE available to healthcare workers.
So Glenn, as a technologist, workflow is king. And, with the recent COVID pandemic, we've really kind of put a dent into a technologist workflow. Now we've got more patients coming through the facility. We've got this infection controls at the forefront. So we're doing more and more cleaning. What do you think are some of the improvements that Carestream has really focused on to help the technologists with their workflow?
Yeah, so Charlie, from a Carestream perspective, all of our mobile systems were actually built with the technologist in mind. So what we call voice of the customer, just customer feedback essentially, is that on how technologists use the systems, how they don't use the systems, what they would like to see improved. So that's how we built our systems, was around that feedback. So, and it's all about workflow. And on the DRX revolution itself, from a hardware perspective, some of the recent changes that we've had is that we've added essentially a second set of collimator knobs onto the collimator itself. So those reside on, now the collimator knobs are on either side of the collimator. And so that just means, so for me as a technologist, I can reach up, adjust my light field from anywhere around the patient that I may be. So if I don't have to now walk around the bedside to reach the collimator knobs, or if I don't have to kind of reach up and underneath the collimator to make that change, certainly better for the technologist. It's just faster, it's quicker, it's just easier. One of the other changes we made was adding detector charging within its storage bin. So that just eliminates the need to have to change a detector battery, more often, I'll say. And then, so if I can just kind of take that, it just takes a few seconds to change a battery, but if I can take that away and don't have to do it, all the better again. So, and finally, one of the last changes we made from a hardware perspective is that we added functional lighting at the base of the column on the system. So what that functional lighting does is just really tells the technologist the status of the system. So green is good, and red is not so good, but then a few colors in between there. So now, with the technologists can kind of keep their distance, whether that patients may be infectious or simply just from a radiation safety standpoint. It's just that functional lighting gives me a visual cue of what's going on with the system without me having to look at a monitor. And then, so that's for hardware. And then on the software side is we've introduced new software recently called ImageView. And one of the biggest changes for that ImageView software compared to its predecessor was just the lack of screen transitions with it. So now everything's that the technologist needs is on one screen, whether that's patient information, technical information, or an image itself, and all the tools that they would need to manipulate that image. And then finally, around the software is that we give the technologists access, the ability to access the HIS or RIS and the PACS directly from the system itself, from its desktop. So really just a couple of screen touches. The technologist then gets into the hospital system, whether that's the RIS or the PACS. They do whatever they need to do into that system. They can close back out of it and then get on with their imaging. So just from an overall workflow, I think Carestream's really worked really hard and done a really good job of just making kind of life, everyday work life easier for the technologists to complete their examination.
I would think that, by putting these workflow improvements in there, that they would be able to spend more time with the patient. Don't you agree?
Yeah, for sure. I think when you can kind of take away some of the niggly stuff that bothers people, Charlie, that certainly they can spend more time paying attention to that patient. Maybe they have a quick word. Maybe they linger for a little while afterwards because it's just, the workflow is such that they can complete their examination a little bit quicker, a little bit faster. Maybe they hang around a little bit longer to help the nursing staff, maybe roll a patient, get them situated properly before they're off to do their next patient, for sure.
Oh. You said niggly. Is that a technical term?
It is. It's a Canadian technical term. Yes.
All right. So we talk a little bit about bedside imaging. I think what first comes to mind is an ICU. Going into the ICU where someone's a patient. But I think there's lots of other opportunities for mobile imaging. What are your thoughts? I mean, where else can mobile imaging be used?
Yeah, for sure. Well, the other question, Charlie, would be is where it can't be used. So obviously, with the pandemic, we've seen temporary spaces being used, whether it was a tented hospital outside on the grounds, whether it was a sports arena or sports dome kind of thing. But from when you're talking about inside a facility, is that that mobile unit will travel anywhere from long-term care to the neonatal intensive care unit to the emergency room to the operating room. So when you talk about something like what it can do for you in the operating room, is that there's really no case that it can't kind of support, whether it's orthopedic, neurology, general surgery. So take an easy, quick orthopedic case is. A surgeon may call you in and they're just looking for hardware replacement just to make sure everything's in line, and they just need to have documented proof of that. And then they just really want 2 quick images, Charlie. And so, they can complete those 2 quick images. The detector goes right underneath the patient. The surgeon manipulates the patient in the position they want, and they take their images. And really, it's as simple as the surgeon kind of rolling back their chair. They look up at the monitor that's above them. They check for position. It looks good to them, and they kind of wrap it up, and the technologist is on their way. So it's really that simple. And the same can kind of be said in the ER as well. So, you may be in there for a trauma case and take a couple images, and then the trauma doctors, they don't really need to go to a secondary location to look at images. They could look images right on the system itself if need be. And then some of our, lastly, like some of our customers will use the portable system as a room on occasion. And that's, it'll be as a secondary room in a backup situation that maybe a piece of equipment is down because of hardware issues or a service call or what might be. So they'll park a mobile system within a space for a short period of time and use that as a room itself.
So just a tremendous amount of uses. As you were talking, I was just thinking that wouldn't it be cool if we could do other things bedside? If I could bring something on our mobile system like dual energy or fluoroscopy or maybe even some sort of digital tomo. What are your ideas of what's your thought of the future? We've seen so much change in the last 10 years. Where do you see the future going in the next 5 to 10 years?
Yeah, for sure. So, 15 years ago or 20 years ago, Charlie, it was hard to see past CR. And so here we are at DR, and it keeps innovating all the time. So when you look at some of the innovation of what's happened in mobile, there's You can get a CT in the back of a van for a stroke patient on their way to emergency. There's now mobile MRI coming into the market. So general imaging will be absolutely no different. So you mentioned fluoroscopy. So now could you have some bedside fluoroscopy without bringing in a large II? Could you look at serial radiography or digital tomosynthesis? So I think as technology changes, as people are living longer, maybe a little bit sicker within the facility, then yeah, you're going to see an advent, quite a large advent of bedside imaging. What can we bring to the patient versus the patient going to you, for sure.
Awesome. Well, Glenn, we're just about out of time, so I do want to thank you for your time tonight. For our audience, I hope you had a great session here and you learned a lot. And thank you again for participating. Stay safe, and we'll see you at our next one.